Thanks, Josh. It's a pleasure to be here at this conference today. It's a particular pleasure to be joining University of California at Irvine. Being a sort of native of a certain university a few miles to the north, it's been a pleasure to transition here, and it's been a great experience to get to know people and begin working with a set of faculty who are so talented, collaborative, and truly visionary. So it's been a great experience in the few months and looking for more to follow. The change in mascots, Bruin to Anteater, but the parking and the traffic, makes up for it. So I'm here. What I'm going to do today is spend a few minutes talking about advances in clinical diagnosis. The issue here, I've been a clinical neuroscience researcher for much of my career, but I've also had the pleasure of working with 5,000 to 10,000 people in clinical visits to understand why they have memory problems and what we might be able to do about it. So what I'm going to do is kind of leverage that and think about what's happening today, reflecting on some of the comments that Dr. LaFurla made and Dr. Kottman about what we know about the disease and translate that to clinical care. I'm going to highlight, I think there's, in reflecting on this, three kind of core advances over the past few years to help us improve clinical diagnosis. And those are jewels, tools, and rules. The jewels I'm calling, because it rhymes partly, but also that these are the kind of shiny objects under the microscope, the things that have enabled us to understand what the protein abnormalities, changes in neurons, and brain structure that happen. Looking at the individual proteins in Alzheimer's disease as well as the other disorders. Tools are the opportunity to kind of see these things in life using things like neuroimaging, fluid biomarkers, and also the tools of clinical assessment so that we're best able to understand for a given individual what sorts of difficulties are they having and what does that pattern of difficulties tell us about what may be going on, what to look for in the future, and how we can best help them. And then finally, rules, that the diagnostic criteria and really understanding what specific features go along with not only which pathologies, but which clinical syndromes brings us all back to this clinical path that we hope to be able to identify and intervene with over time. We're highlighting here 30 years of advances. I'm going to add a couple zeros to that just for entertainment value to go back to some of the earlier things and concepts of dementia, things to highlight here that I find interesting. One is early on the idea of will and the concept that that effort and who you are as a person has an impact on how your brain's working essentially. Secondly, and probably most importantly, if you get down to the 19th century in particular, the idea that the brain and behavior are linked. Oops, that what happened? There it goes. And that there were the neuropath studies at that point were really looking at the base of the brain, partly because it was easy and it's there, and noticed that hardening of the arteries, you've heard that term, and big vessel atherosclerosis was common in people who had memory problems. And so this idea of vascular changes really driving cognitive deficits and the syndrome of dementia got its start there. The Etienne Esquirol in 1838 put together his differential diagnosis, shown there on the right, of the different things that cause dementia, mostly highlighting that even at that point in the 19th century, the link to age, that progression of age was thought to be the most common etiology. And then throwing in, pick your favorite from the slide, mine are severe weather conditions, which we're facing today, and I guess unfulfilled ambitions, since it's part of the human condition. Then post-19th century, Professor Alzheimer comes along in Germany, a psychiatrist who worked in the equivalent of the state hospital system in Germany. He took advantage, and this is now where the tools come in, that he was able to use staining techniques that were newly available. Franz Nissl, one of his colleagues, who's actually in that picture, but to the right, and I had screened him out, developed opportunities to look at what's in the brain using particular stains that highlighted what were the amyloid plaques of Alzheimer's disease. So these tools provide an opportunity to learn more about, among people who have these cognitive deficits, what might be driving that in the brain. The trick here, the oddity or weird coincidence, is that his index case was a 51-year-old woman who had obviously very early onset Alzheimer's disease. And this started, Alzheimer himself was convinced at the time that it was a syndrome of pre-senile change, to come to your question, that only young people develop these amyloid plaques. It was a hypothesis, obviously, but felt strongly about that. And there's like divergence where young people with memory impairment, it was related to Alzheimer's plaques. Later on in life, it was related to hardening of the arteries. So it turns out that that dichotomy that actually made sense at the time, but in retrospect is not correct, permeated the literature and our thinking for 50 years or more. Then fast forward to the 1960s with the seminal work of a number of people, most notably the group of Blessed, Tomlinson, and Roth, who looked at brain tissue and recognized in older people and realized that yes, older people too who have cognitive disorders have amyloid plaques and neurofibrillary tangles, and that there's a relationship between the extent of memory impairment and those pathologic changes, kind of pulling apart or putting together, I guess more accurately, the senile and pre-senile dementia syndromes. Then to come to some rules, in 1984, the first, I think there were earlier versions through the DSM in psychiatry and some other nosology tomes, but the NIN-CDS, a branch of the NIH, and the Alzheimer's Association forerunner, put together a group and came up with diagnostic criteria for clinical diagnosis of Alzheimer's disease. And as most of you are aware, the best we could do at that point was probable Alzheimer's disease. The thinking being the only way you can diagnose true, definite Alzheimer's disease is with brain tissue. And it includes, it's hard to read here, but the points are the usual, that it requires cognitive impairment, insidious onset, gradual progression, involvement in more than one cognitive domain, commonly memory, and something else like visuospatial skills, language, etc. I found of interest that at this time, the functional disability, the challenges with doing one's usual activities, functioning in the community, at work, and socially, was not a specific requirement, although that was kind of implied and certainly supportive. So the first time, there are some decent rules of what is probable Alzheimer's disease. It didn't include a syndrome like mild cognitive impairment. At that point, the awareness of what that might mean just had a lower intellectual valence, and people didn't really understand what was a forerunner of this disorder versus what was cognitive aging, the experience that we all have of slower, less efficient learning and recall as we get older. Then if you look at what happened after 1984, this is the kind of the PubMed citations broken down by decades since the 50s that use keywords of Alzheimer's disease and clinical diagnosis, highlighting the dramatic increase in the research literature on how do we think about clinical diagnoses in Alzheimer's disease. And I think a lot of this is a consequence of having those clear criteria. When folks know what they're talking about, there's a common language, there's an opportunity to share information, and the path of new learning in the field increases substantially. So for the remaining minutes, I'm going to kind of highlight what I think are some of the things that have contributed to better clinical diagnosis. And these are some themes that kind of permeate along with the jewels, tools, and rules, how we're better able to diagnose, and particularly now, to understand who has syndromes that are going to be amenable to treatment. As new treatments become available, they will only be effective in the people who are going to respond to that treatment. That's sort of hardly a great truth, but if the field is muddied on who has what symptoms, if we just lump things together, that heterogeneity will likely make it very difficult to apply new treatments to the people who will actually benefit. And the key advances that I'll touch base briefly on each over the next few minutes. One is longitudinal studies. In the past, Alzheimer had a brain from one person, one syndrome. We now have the opportunity to look at how people change through the Alzheimer's Centers program, for example, over years or decades, what clinical symptoms do they have? What sorts of memory difficulties? How much do they change over time? How much variability is there in how it changes over time? And that's really provided a great opportunity to kind of understand what these illnesses are and help define sets of people who have common symptoms. Second, neuropathology in relationship with clinical symptoms, to be able to link the neuropathology that we can see to what clinical symptoms are there. Biomarkers I'll talk about for a moment, but recognizing that Dr. Jagus is going to talk about that more later this morning. Refined clinical diagnostic criteria, a few words on that. What isn't Alzheimer's disease? That understanding what is Alzheimer's disease is important, but we have to figure out what to do with the remaining proportion of a third or more of people who have a cognitive disorder. What is it and how do we distinguish it? And then finally, the role of distinct cognitive and non-cognitive symptoms. How do we put the patterns of symptoms that people have into these clusters we call Alzheimer's disease clinically? With regard to pathology, I'll make one point, and Julie Schneider is going to speak later this morning in much more detail about pathology. But the point that I'll make, that she, I'm sure, will elaborate on in much greater and elegant detail, is that Alzheimer's pathology isn't alone. That if you look at people who, at autopsy, have the neuropathologic changes of Alzheimer's disease, far more than half of them have other pathologies, proteins that are abnormal that aren't Alzheimer's disease proteins. So you're not just dealt a card with one pathology in your brain, that in fact it's a broad range of abnormal proteins that make the work that Dr. LaFerla in mouse models to be able to understand how best do we put these collaborative proteins together into a model. The purpose here is about clinical diagnosis, and the point is that when we think we're looking at Alzheimer's disease, this person has plaques in their brain, we're often going to be wrong just playing the odds because they usually have more than just plaques. Clinicians aren't always seeing Alzheimer's pathology, unfortunately, and that a high proportion of those with, quote, pure Alzheimer's disease at autopsy were thought to have a non-Alzheimer's diagnosis during life. So our clinical criteria behave reasonably well, but are far from perfect, and the advancements there linking this pathology that we see to the actual clinical symptoms will be helpful. This is the kind of obligatory slide that every Alzheimer's talk has about biomarkers, and this includes the proteins and brain changes that occur on the left-hand side, amyloid, tau, neurofibrillary tangles, and when biomarkers such as imaging modalities looking at amyloid and tau, cerebrospinal markers, when that changes. And the green band to the right is clinical memory problems or dementia. So that there's this set of events that occurs 15 to 20 years prior to developing memory impairment. And I highlight this because with the enthusiasm appropriate for biomarkers, we're also going to have difficulty wrestling with the fact that these folks don't have memory impairment. The good news is that we can identify these abnormal proteins before you have memory difficulties. The bad news is in the clinic, that will be invisible, so that it's going to take some time to figure out how do we map that information onto how we see patients in the clinic, understand what their prognosis is going to be. You're starting to see a shift here towards a biological diagnosis rather than a clinical diagnosis. There are also a whole host of factors that play a role in the translation of these changes in biology to the expression of cognitive symptoms that include a range of things listed here that complicate the picture even further. So in the clinic, we're trying to tease apart these syndromes, and yet the deck is a bit stacked against us because of all these changes, particularly in the earlier phases. I won't spend a lot of time on biomarkers because others will be today, but just to highlight, we can image amyloid and tau in the brain. The top panel on the left shows amyloid image of someone who has amyloid in their brain on the right and who doesn't on the left. So you can see the brighter colors. That can be done fairly easily by scan. At the bottom row is the tau imaging, seeing the abnormal protein of tau. in the brains and how it spreads from left to right as the Alzheimer's process unfolds. A challenge facing us now, and this will grow in the future, is how do we apply that clinically? Amyloid imaging, there are 3 amyloid imaging techniques that are currently approved by the FDA in the United States, and any of us can go get an amyloid scan today. The question is, what do you do with that information? Obviously, as anti-amyloid treatments are available, that will be extraordinarily important. But right now, it's less clear about how we can best use that information and who would benefit from having an amyloid scan. You know, the current thoughts that people have listed on the right here are in the clinic, and we're ordering them on relatively infrequent occasion when somebody has something that kind of looks a little bit like Alzheimer's disease clinically, but there are a number of features that really go against that. If it looks like Alzheimer's disease clinically, in practice in 2019, that's probably good enough. But if there's something that's prominently unusual, where you want to get another piece of information to understand, does this person have an amyloid-based illness? And my belief is that amyloid imaging is probably more useful when the scan is negative rather than when it's positive, which is not how people usually think about it. But because positive amyloid scans are so common in older adults who are cognitively normal, and we don't know necessarily what's going to happen over time, that somebody who's got some memory difficulty already, who doesn't have amyloid, really moves us clinically from thinking away from the typical Alzheimer's pattern. There's been some nice work looking recently at how does amyloid imaging change how doctors think about care, and published the IDEAS study that was just allowing clinicians to order amyloid imaging and then tracking over time. Did it change their diagnosis? Did it change management? And interestingly, the change in diagnosis was substantial. The changes in treatment were actually more robust. And it's a good example about how clinicians are doing the best they can and hopeful in using information to be accurate. Whether that's necessarily valid or not is a little bit questionable. And in this case, a fair number of people were started on anti-dementia medications with the presence of a positive amyloid scan that the clinician didn't feel that they needed to be on previously. But with an amyloid scan, the clinician says, gee, this is an amyloid-based disorder, therefore an Alzheimer's treatment may be helpful. Good thought, and there's some evidence that that may be helpful, but on the other hand, there's not a lot of evidence that dementia medicines help at the phase that these people are in with mild cognitive impairment. So that in 2019 is probably of less value, but for the future will be really, really important when we have anti-amyloid treatments. There's other biomarkers available, again, not to belabor it. We've done some work looking at cholinergic receptor binding in people with older adults, some of whom have memory difficulties, to highlight what's happening with neurotransmitter systems and broader systems than just proteins in the brain, highlighting some very, very early changes, some clear links to specific clinical symptoms, and some impact on treatment. That bottom right box, it's hard to see, a paper that was published in Brain last year highlighting that the response to cholinesterase inhibitor medication was driven by the presence of a cholinergic deficit regionally in the brain, so that it's an opportunity not only to look at who has what disorder, but who's going to respond to treatment. And that's obviously going to be very, very important in clinic. We can measure these biomarkers in a variety of ways. Fluid biomarkers is the non-imaging way. Cerebrospinal fluid drawn through a spinal tap or LP can do much of what the brain imaging can do. There's some evidence that actually may be more sensitive for early changes, although that's controversial. There's some challenges because the laboratory assays vary a bit around the country, so there's some concerns, but there's other non-imaging ways of assessing these things. And finally, blood plasma. I mean, if you want to look at something in the body, blood is relatively easy to get through just a regular venipuncture. Unfortunately, right now, the evidence really doesn't support current testing of blood plasma for Alzheimer's markers. That will likely change. The challenge is you've got small amounts of protein that are coming from a distant place, into the bloodstream and get diluted with a whole bunch of other stuff that's in blood, lots of protein that's normal. So to be able to kind of see that with the assay is currently not easy to do, but that's changing, and to be able to look at other processes as well. So then to come back to some rules that with biomarker evidence then, the diagnostic criteria shift 6 to 8 years ago in looking at what role does biomarkers play in our understanding of diagnostic framework. And this too is a busy slide, but highlights in the blue rows when you have a biomarker present. So there's the clinical diagnosis of memory impairment, other changes clinically, but then what do the biomarkers show? This is predominantly to be used as a research tool and to be able to track people over longer periods of time to understand prognosis and course, but is now embedded in our diagnostic framework. So there are different terms for having preclinical Alzheimer's disease. So that's a bit of a idiosyncrasy in that you're saying it's Alzheimer's disease, but preclinical, meaning no symptoms. So these are folks who have the biomarkers and likely have the abnormal proteins of Alzheimer's disease, but yet have no memory difficulty at that point, as can be revealed by imaging and cerebrospinal fluid. So now our criteria are starting to include these biomarkers in how we think of the illnesses. It's always good to have a citation of Humpty Dumpty in any presentation, is my philosophy. On this one, says Humpty Dumpty, when I use a word, Humpty Dumpty said, in a rather scornful tone, it means just what I choose it to mean, neither more nor less. And what's happened in Alzheimer's disease recently is a shift towards defining, quote, Alzheimer's disease as a biologic illness. So you have, by definition, Alzheimer's disease when you have this abnormal protein. It's controversial. I was part of a research roundtable in Washington to kind of discuss the implications. There's big things that it means about how we diagnose, about how we communicate more than anything. And the focus is to understand what the protein is that people have as we move towards biologically based treatments, but at the same time has a big impact on clinical understanding, about communication, and this slide kind of highlights the complexity of these things. When you break things down by having amyloid, having tau, and having other elements of neurodegeneration, that's the A-T-N spectra. And if you're A plus, T minus, N plus, you have a certain thing called a certain thing. And for all those combinations, a good idea and really helps the researchers communicate about who's being included in treatment studies, who's being included in pathological studies, at autopsy, who are we tracking clinical symptoms over time based on what they have biologically. A powerful research technique. It has the capacity to make the communication among people, clinicians, and researchers pretty challenging, and it's had that impact already. And there's controversy about should you call Alzheimer's disease based on a protein rather than a syndrome. The next thing to speak briefly about is what isn't Alzheimer's disease. And along with criteria or the rules for Alzheimer's disease improving, there's been a substantial improvement in criteria for non-Alzheimer's dementias and our ability to accurately diagnose things like dementia with Lewy bodies, that there are also biomarkers for and opportunities to look in the brain in life to see what's going on that may reflect the abnormal Lewy bodies of this disorder. Frontotemporal dementia also has fairly clear and reasonably sensitive and specific diagnostic criteria. So in the clinic, when we apply these rules, we're better able to sort people, at least into homogeneous groups, that allow us to do things like predict what to expect over time, to be able to predict whether or not they may respond or not to currently available treatments. And more importantly, as different treatments become available in the future, who's going to benefit from them? Because that's going to be, as I've already mentioned, extraordinarily important. The final area here is kind of the profiles of cognitive and non-cognitive symptoms, that we've gotten better at looking at things beyond memory And one of the more interesting advances in my mind is the psychiatric symptoms that are now known to be kind of part of the Alzheimer's process. We used to think that people with advanced Alzheimer's disease unfortunately had such global brain disruption that they were sensitive to behavioral changes, irritability, angry outbursts. But it's clear now that there's a much more specific course of these symptoms, that some work that we've done and others show that there's certain parts of the brain in your Alzheimer's disease that affect the likelihood of whether you have delusional thoughts, irritability, agitated behaviors. So there's a biology not only to memory, but also to these non-cognitive or psychiatric symptoms. There's also an awareness recently that these things can happen fairly early, and that the psychiatric symptoms that are common early, such as anxiety and apathy, folks with relatively mild memory impairment who are destined to develop the clinical syndrome of Alzheimer's disease, often have symptoms like apathy or an anxiety. And this comes from work, it's a little hard to see as well, but the point here is when you track people over time, whether they have the ApoE4 gene or not, which we know is a risk factor, and whether they have anxiety or not, and just sort people into one of four categories: ApoE4, yes or no; anxiety, yes or no. And then follow those people over, and this study was 4.5 years. The change in memory over time is dependent not only on the ApoE status, but also on the anxiety status. And the two lines at the bottom that slope downward the most dramatically, the lowest one is for those who have an ApoE4 gene and anxiety at baseline, and the one above it is ApoE4 gene, but without anxiety. So anxiety and some other changes are really potentially driving the amyloid toxicity when it comes to memory, at least. So there's a much more important, clever, and interesting picture about how symptoms emerge in clinical Alzheimer's disease, what it means, and how we can work with it over time. This has progressed to the sense of there's a syndrome now called mild behavioral impairment to kind of mirror the mild cognitive impairment of potentially early Alzheimer's disease, so that we've put together kind of a list of rules again to identify those who have a significant and enduring, sometimes subtle change in anxiety symptoms, apathy, emotional dysregulation, so that we can understand how much that can tell us about what happens over time and the development of a cognitive disorder. It also helps us consider those folks as having a different kind of an illness and away from seeing them as someone who has, for example, a traditional psychiatric syndrome, such as major depression, that you would treat quite differently. And so it's an opportunity to really understand where people may be headed and how we can best intervene now and in the future. So in the final just couple minutes, questioning the issue about, okay, so how do all these advances actually improve diagnosis and benefit care? I've highlighted some already, but just to wrap up with a couple of reminders. It's not always easy. There are significant challenges to detection and accurate diagnosis that have to do with everything from the complexity of heterogeneous symptoms to the fact that most Alzheimer's disease or cognitive disorders care is provided in primary care. Many primary care docs are really, really good at cognitive disorders. Some just have less experience, so it's difficult to manage people with cognitive disorders or diagnose them in usual clinical settings with great variability. The healthcare system doesn't make it easier when appointments are 20 minutes long to be able to do a thoughtful cognitive assessment. So there are certainly challenges. In 2019, what clinicians are doing when considering a cognitive disorder are the usual things shown on this slide. Not a whole lot of change in this over the past 5 or 10 years. I highlight it because a couple things have changed. One is psychiatric symptoms I've already mentioned, and to be looking for early, subtle psychiatric changes that don't mean that someone has a newly emerging traditional psychiatric disorder, but may be part of the evolving cognitive syndrome. The second is in cognitive assessment, that in order to address the fact that time is limited in clinical evaluation, to use our tools and rules to do the best we can in getting accurate diagnostic information as efficiently as possible. And that's really gotten better, I believe, through the use of some tools like the MoCA that's a little bit more sensitive than mini-mental state, that it's an opportunity to have a score that gives you a sense about where someone fits. It also gives you a sense of how they're doing in different domains, cognitive domains, how's their memory compared to language, for example, which is diagnostically very, very helpful. Some cognitive disorders have more memory difficulties, some have less compared to other cognitive deficits. And then finally, with MRI imaging, that's been, as Dr. Kottman described, around a long time and really helpful in understanding how the brain looks and are there any major lesions seen on brain imaging structurally. But we're now also able to look at things that are more subtle, like the hippocampal volume, that some institutions now, their radiology departments are actually reporting the volume of the hippocampus in cubic millimeter. And you can kind of think of that on a scale of, is somebody at the 80th percentile, 50th percentile, or 20th percentile? And that's going to have prognostic value in understanding what to expect over the future, as well as diagnostic value, because Alzheimer's disease affects the hippocampus structurally and grossly first. Also to look at patterns of regional atrophy, that the machines are fairly sensitive to that now. To look at small vessel cerebrovascular disease. We're now aware that people who have these white matter connecting neuronal tract ischemic changes related to blood flow problems are much more likely to have memory difficulty with a given amount of amyloid in their brain. The vascular changes leverage the neuropathology of Alzheimer's disease. So it's really helpful in understanding who's susceptible to that based on imaging, and who should particularly have their vascular risk factors managed as aggressively as possible to prevent further decline. Some other specific tools that are used now in diagnostic evaluations. Fluorodeoxyglucose PET is a different kind of PET scan that looks at metabolic activity, how the brain is, how cortical systems are working together, which can be helpful because Alzheimer's disease clinically is a disorder of systems. It's how parts of the brain aren't talking to each other as efficiently or accurately as would be ideal. And FDG PET can look at those systems changes. Other scans like DAT scans that look at dopamine neurotransmission to help us distinguish dementia with Lewy bodies from Alzheimer's disease. The DAT scans are significantly different. Amyloid PET and CSF biomarkers I've already talked about. So in clinic, we're using them quite rarely in 2019, but in selected cases. And genetic testing when someone has the pedigree that accounts for the small proportion of people who have a true genetic autosomal dominant form of Alzheimer's disease. So I'll stop there. I've covered on the left-hand side there these different aspects of new changes in what we know about the disorder, how to diagnose this, the categories of things. This is a work in progress. We're still not fully accurate, even with the use of biomarkers, because we know that pathology varies across everyone, that it's difficult to know clinically exactly what's going on in the brain, but obviously important as we have new treatments. Next steps include what I consider embracing the heterogeneity. We're not going to be able to sort people into you have amyloid, you don't clinically, but to be able to refine our thinking so that we can do the best we can probability-wise, as well as to identify who has other syndromes. Practical assessment community I talked about, biomarker advances you'll hear more about from Dr. Jaggist, and how we can use them clinically will have an important role to play. And I think at that point to stop and wind up with optimal candidates for specific interventions as we have anti-amyloid treatments, understanding who, not just biologically, but clinically is going to benefit. It's going to be very, very important, and be able to understand who we can offer new treatments to, who will be able to benefit from it. So I'll stop there. I hope that's helpful. I've moved quickly, but hopefully we're back on time a bit, and thank you for your attention.